Beautiful. All right. Welcome. Wonderful to see you all in this cold February. We're gonna have some snow later on this weekend. I hope you all are warm and cozy where you are. A reminder, you can do closed captions in Zoom, and we have the buttons on the screen here. And if you have any trouble with it, just type into the chat, and Ellie and Cora and Liv will help you to get closed captions. Next slide.
Hold with me that I'm trying to get the caption started and I'm missing the button. I think Zoom moved it, so bear with me for a second, everyone.
Bearing with you. All right. I will just remind us that this is a NIDA-funded initiative to advance the science on recovery community centers. Our goal is to bring together our diverse group of people, including people who lead recovery community centers, who participate in recovery community centers, who fund them, scientists, clinicians, anybody at all interested in recovery, all are welcome. And our goal here is to learn from each other and to share what we have. And I will say that today we have a presentation by one of the pilot study teams that was funded. So this program funded by NIDA made pilot study funding available to teams. And the goal is for these teams to get early data to inform more research and build bigger projects going forward. One of these teams is here with us today and will present. And I'm asking everybody in the room to chime in with things you want them to think about as they're building this area of research, certainly on the findings that they have, but also they're here to learn from the collective wisdom and collective expertise in this room. How are we doing on closed captions? Shall I go to the next slide, Liv?
We can continue. I don't know where it is. I'm asking Cora and Allie if they see the button because I don't see the button anymore.
All right, sounds good. Then next slide. Also, reminder that our group is part of a larger consortium on addiction recovery science that we founded a couple of years ago. In microfiche, you will see a variety of opportunities here. You will get the slides next week, probably Tuesday, Wednesday, and they're also, of course, available on the website thereafter, so you can, at that point, click on things. But please know that there's opportunities for conferences, for community board initiatives, and so forth. So do take a look to become at the opportunities to be involved in a variety of projects in the recovery support services space. So not specific to RCCs, but more broader recovery support services. Perfect. Next slide, please. We maintain a list of recovery community centers nationwide. This list is growing as well as changing. If you know about a new RCC or an RCC that's not on our list, we greatly appreciate if you can drop us a note. You can click here to see who we do have on our list and then email us with who we are missing, or don't even look at the list and just tell us who we should know about and we'll check if we have them. We maintain this list for anybody who wants to collaborate with recovery community centers. So when people learn about recovery community centers and say, that's amazing, who should I reach? Who is near me? We give them this list and say, well, so-and-so is 50 miles from you, is 3 miles from you. So please help us build out this list. Next slide. Now, speaking about pilot studies, those of you who are here often, you might recall Dr. Brown and Castillo de Mattel presenting on a pilot study about the development of a cost-effectiveness calculator for SUD outcomes, and specifically geared towards recovery community centers. Shelton, are you here at the moment? Okay, he might have been here, but
Yes, I'm
oh,
here.
perfect. Do you want to pitch about what it is you're asking for this group and how to help you with your next step?
Sure, I will just so I don't. I'll put the both links in the message, the chat there. But basically, what we did is we did a couple of pilot grants from an R24, and basically what they are is we're pitching them towards recovery communities, RCCs, and other community organizations who are trying to advocate for funding, like HRSA grants and things like that. And we were thinking that it's set up so you can plug in numbers like from your organization and get a decent cost effectiveness analysis outcome, like averted cost in the judicial system. We're going to try to make it more localized, and we're going to put in an STTR, and our idea is to like have a small subscription fee so we can do more And then people, when they write their grants, would be able to, to have that as as something to argue for, like our program offset this many costs. So that's sort of the idea. And so we have like a survey about like willingness to pay and things like that. Because, if you're writing a STTR grant or SBIR, you kind of have to show that you think you have some customers or they're not going to give you the money. So that's the idea. We're not trying to get rich. We're just trying to like spread out the information. If we had a little bit of money, we could probably do more, and there would be more funding for SUD recovery.
Perfect. Thank you.
I'll put the links in for everyone. I'll put the calculator in, and you can play around with it, but I don't want to distract from your presentation. And then I'll also put in the survey. Okay.
Yeah, absolutely. I put all the links. We put a couple there. We link back to the original recording from when you presented in this series, and the link to, I think, the calculator as well. But add all the other links for the survey as well. That'd be wonderful. Add as much as you want.
Thank you.
Beautiful. All right. So this is how we're all building the Science and Recovery Community Centers together. Wonderful. Thank you. Next slide. Pasadena, are you here with us? We were going to have a live feature from New Life 2 in Connecticut, but it seems we were discussing earlier this week with Pasadena, but there seems to have something come up. So unfortunately, today we will not have a live feature, which means our presenters will have a little bit more time to present their data. So I will move us on to the next piece. Polling questions, you know them all. We basically do it to capture who we have in the room to see if we're actually reaching our many different key community groups when it comes to building the Science and Recovery Community Centers together. Kindly fill those out. You can use the gray bar on the right to scroll you through. And then when you answer all the questions, the submit button should turn blue and allow you to submit it. The last two questions are previews to the presentation to come. So I'll give you a few minutes to fill this out. And Liv will be monitoring to see what the percentage of the people in the room is for completing this. We usually try to get 80%.
Yeah, we're at 40 right now.
Do you want to give it another second or?
Oh yeah, we have another. It's going pretty quickly. I think we'll be there soon.
Cool. Very nice. And then once we have the results, you can all scroll through it on your screen, and Robert and Ryan will be able to see to what degree people are already ready for the information that they're about to get. How are we doing?
75%.
Ooh, so close.
Hasn't moved in. Still at 75%. Doesn't seem to be moving. Oh, just got one. Okay, we're at 80.
Beautiful. Thank you, everybody. All right, let's share the results. So if you want to scroll down to the last two questions, which are our questions about the presentation. The question was, RCC directors of rural RCCs in Georgia highlighted challenges, except which one do you think is not a challenge? And the main competitors here are many RCC participants do not have a high school education, but we're pretty split vote. So we will see what we will learn about what are the challenges and not the challenges in rural Georgia. Then in thinking about rural RCCs compared to RCCs not in rural areas and the kinds of challenges that they are facing, if we have an idea here, 50% of us thought that the challenges that they face are similar but different. Only a few of us thought that they were largely the same, and some of us, 39% of us thought that they were in fact markedly different. So let's keep a lookout for the results regarding that. And Michael thank you for sharing that about Pasadena. So all of we'll be sending him our best wishes and positive thoughts and lots of energies for his swift recovery. Thank you for letting us know, Michael. Next slide, please. All right. Here are our two presenters for today who are recipients of a pilot study funding and hoping to give back to this group here about the findings they have and to learn from the wisdom that we have assembled here. Robert and Ryan, I was going to say take it away, but before I do, I will mention, and if you can just go to the next slide real quick. Following their presentation, we have Delesha Carpenter with us as well as a discussant who is going to give some feedback about, from her perspective and from the work that she is doing with rural communities, how what she has heard in this presentation relates to the work she is doing. And that's only the beginning of our discussion. Everybody is, of course, always welcome and invited to chime in as we go through our slides. And Delesha will be participating in our discussion as well. So now we can go back to the previous slide or the next slide, and I can say, Robert and Ryan, please take it away. Excited to hear what you have for us.
All right, thank you so much, Bettina, and thank you everyone for taking the survey. So Ryan and I are from Georgia Southern University, and today we'll be presenting on recovery community centers in rural areas, addressing unique challenges to better serve individuals with opioid use disorder. Next slide, please. All right, so why study RCCs in rural areas? Well, we know from the literature that problematic substance use patterns and treatment access for substance use disorder are different in rural areas, including treatment access for medications for opioid use disorder, or MOUD. There are rural-urban differences in social networks and addiction stigma. Rural areas face unique challenges, especially related to social determinants of health, things like housing, education, transportation. Rural RCCs are likely to have much larger service areas than their urban counterparts. Since RCCs are typically designed to be tailored to the populations they serve and address unique challenges and needs, we hypothesize that RCCs may function differently in rural areas and play a special role across the SUD continuum of care, including prevention, harm reduction, treatment, and recovery. Next slide, please. So to examine RCCs in rural areas, we took a two-pronged approach of both interviewing RCC directors and surveying RCC clients. So in Georgia, we have about 40 RCCs, with many of these located in rural areas. We enrolled 12 out of the 13 RCCs that we reached out to into the study. So the map on the right shows the location of these RCCs. We administered online pre-interview surveys and conducted semi-structured interviews with RCC directors. The interviews lasted about an hour, and we had a $50 incentive. And we administered surveys to RCC clients, and we had a $10 incentive for the survey. Next slide, please. So to give you a little snapshot of our RCC director methods, so the pre-interview survey captured services offered by the RCC, client characteristics, operations and budget, and demographics and medication attitudes of the director. During the interviews, we asked about challenges faced and how the RCC overcame those challenges, lived experience of the director, including lived experience on MOUD, inclusion and services oriented to clients on MOUD, relationship with community partners like the criminal legal system, community-based organizations and treatment providers, especially asking about relationships with MOUD providers, if they were delivering harm reduction services, if they experienced stigma and how the RCC had tried to address stigma. And we also asked about RCC organizational factors like funding, data collection, and sustainability. So the data collection and analysis is finalized, and this is what we will be primarily presenting on today. Next slide, please. And for our RCC client survey, the things that we asked about in that instrument were demographics, clinical characteristics, RCC experience of being a person in recovery, living in a rural area, services utilized at the RCC. We had metrics that measured well-being outcomes like recovery capital, social support, psychosocial stress, quality of life. We again asked about medication attitudes, and this data collection and analysis is ongoing. And we did run into some challenges that Ryan will discuss later with the data collection. Next slide, please. So our survey results for RCC directors, RCCs serviced an average of 41 new members per month, had an average of 960 visits per month. Their average annual budget was $225,000, and this was mostly funded through a state contract. Directors reported the most important services to be mutual help organizations, or MHOs, and one-on-one peer support. The directors estimated that most of their clients were early in recovery, had criminal legal involvement, and were middle-aged, and about half lacked a high school education. The directors reported that the most common problem substance for clients was methamphetamine, followed closely by alcohol and opioids. Most RCCs served a predominantly white population, which typically mirrored the demographic of the area, but 3 RCCs served a predominantly Black population. Most referrals to the RCC came from the treatment or criminal legal system. Next slide, please. So our qualitative analysis results, the results of the interview, transportation was the most frequently mentioned challenge faced by the RCC, and most RCC directors cited transportation as their biggest challenge. The directors mentioned having a large service area, the lack of public transportation or rideshare options. So one director said, "We have recovery options and can help people get to them, but with rural areas, everything is so spread out. There may be resources in our region, but the region is so large that people can't necessarily access them. For example, even with my transportation resources, the nearest detox center puts my drivers out for 2 hours, an hour there and an hour back. Without us providing transportation, people wouldn't be able to get there. So even though a service might be considered local, it can still be hours away from someone who needs help." Next slide, please. So housing was the second most frequently mentioned challenge. The directors talked about limited affordable housing options, especially in the context of rising rents and housing prices, limited recovery housing options, lack of shelters for unhoused people, and they talked about their clients facing barriers like upfront costs, poor credit scores, and criminal backgrounds. So a director said, "Another major challenge is getting people housed when they leave treatment. It's not about the financial barrier of first month rent and deposits. Many of them have poor credit scores and a criminal background, which makes it even harder." Next slide, please. So some other challenges that were frequently faced by RCCs, limited resources, including treatment services and MHOs, employment challenges. Many RCC clients did not have a high school education, health insurance access, especially since Georgia is a non-Medicaid expansion state, lack of affordable child care services, stigma faced in the community, and somewhat surprisingly, we asked all the RCC directors about difficulties with internet or broadband access, and this did not seem to be a problem, according to most RCC directors. Next slide, please. So how did the RCCs overcome these challenges? Well, for transportation, sometimes the RCC had their own vehicle. There were a few RCCs that had more than one vehicle. Although this wasn't ideal, some RCCs, the staff and volunteers used their own personal vehicles. They used rideshare when it was available. They collaborated with community partners. And we did hear about one RCC that provided daily trips to the local opioid treatment program for their clients. For housing, this was one that RCCs were really challenged to address. They tried to collaborate with community partners. They connected with local property owners to try to encourage them to rent to people in recovery. Some had funds dedicated to cover upfront financial costs, particularly for recovery housing. Other challenges, the way that they were addressed for employment, building relationships with local employers, as well as providing a space like access to a computer in the RCC to do job searches. For education, a lot of RCCs connected to GED programs in the area. And for limited services, nearly all RCCs provided a private space for telehealth services. And many of the MHOs were offered virtually or in a hybrid format. Next slide, please. So a theme that ran throughout our interviews was that becoming embedded in the community and strong collaboration with community partners are key for RCCs. RCCs collaborated with the criminal legal system, entities like accountability courts, probation offices, jails, and law enforcement. Some RCCs had staff that were specifically trained as forensic peer mentors to work in these settings. Some RCCs were in the jail and provided reentry support both before and after release. RCCs collaborated with social services like the Department of Family and Child Services, shelters for unhoused people, and local nonprofits. Something we heard a lot about was that the RCC directors often sat on the board of directors for other nonprofits in the area, thus strengthening and fostering those relationships. RCCs collaborated with a wide range of treatment services, detox facilities, state-funded treatment facilities, office-based buprenorphine treatment providers, FQHCs, and residential programs. Next slide, please. So an interesting finding in this study was that collaboration with MOUD providers was minimal, despite RCC efforts, especially for opioid treatment programs or OTPs. Since these RCCs were located in rural areas, not all of them were located close to an OTP, but for the half that were, only one had a strong working relationship with the OTP. So I'll read the first and the last quote here. So the first one, I don't actually have a good relationship with our methadone clinic here. I haven't tried it in a little while because we got a lot of pushback last time. They let me leave some flyers on their counter, but that's about it. I'm working on getting a harm reduction box installed at the methadone clinic through Georgia Overdose Prevention, hoping to build trust and show we're here to support and help. And the last quote, after the phone call, I probably would never reach out with them again. It was pretty obvious it was a shady thing because I said, what's your accreditation? And he said, well, we're not accredited. So how do you bill for Medicaid or anything else? I asked, and he said, oh no, we don't do any of that. It's cash. Next slide, please. There also appeared to be difficulty engaging patients at OTPs. So one director said, yeah, we're friends with them. I guess that's what you'd call it. It's really hard to get the people who participate with them to come out and do things with us. I don't know if they're afraid of stigma or if they're just like, leave me alone, I got my medicine. We tried to start a medication-assisted recovery meeting, but didn't really have much luck with their clients. They do give out our information to people and vice versa, so I guess it's as good as it can be right now. Next slide, please. So some of our study findings were that RCCs provided critical linkages to treatment and helped clients overcome treatment barriers. RCC staff were in labor and delivery health centers, jails, emergency departments, and some were a part of post-overdose response teams. So one director said, for treatment, being part of the RCO network is invaluable. We have a big network of people we can call for referrals or help finding available spots in detox or long-term programs. After 5 years, I know who to reach out to in most towns to make things happen. Collaboration really is the key. And another director said, detox is a huge part of the process. I've taken about 10 people to detox this week alone. Next slide, please. So all RCCs that we talked to distributed naloxone and were often the only or primary naloxone distributor in the area. So a director said, if we weren't doing it, there would be a significant drop in availability. Many organizations, schools, police departments, and others rely on us to provide it. And it wasn't just naloxone distribution. Several RCCs also reported being instrumental in overcoming stigma towards naloxone. So a director said, when we first started, there was resistance. For instance, during an early meeting with community leaders, some wouldn't even touch the Narcan we were passing around. Now those same individuals sign out Narcan kits and distribute them. Next slide, please. So all RCCs offered MHOs representing recovery pathways that would otherwise likely not be present in the area. So beyond your traditional 12-step meetings like AA or Alcoholics Anonymous. So this is just a snapshot of one of those RCCs. The director said, we have Celebrate Recovery on Wednesday nights, Faith in Recovery on Saturday nights, and we just started a Veterans for Veterans meeting on Sundays. So we have support groups 7 days a week, an hour each day. The all recovery meetings on Tuesdays and Thursdays and the 12-step meeting on Saturdays are the only ones during the day. So we have those 3 times a week for peers who may work third shift. We have evening meetings for those who work day shifts. Next slide, please. So 6 RCCs reported starting MHOs specifically for clients on MOUD. Such as Medication Assisted Recovery Anonymous or MARA, but half had difficulty sustaining them. However, several RCCs have been successful. So a director said, we have a Medication Assisted Recovery support group on Monday evenings, which has been very successful. People come from surrounding areas because they feel safe to discuss this recovery pathway, which isn't always accepted in traditional meetings. Other RCCs noted that clients on MOUD attended and felt comfortable in all recovery meetings. Next slide, please. All right, I'll pass it over to Ryan.
Thanks, Rob. Hi, everyone. My name is Ryan Lofaro. I'm in the Department of Public and Nonprofit Studies at Georgia Southern. And the part of the analysis that I focused on was looking mostly at lived experience and directors' lived experiences in addiction recovery and how this helped them to provide services to their peers, and specifically how it helped them to help their peers with things like stigma, community stigma, and stigma toward MOUD. So as for our director demographics, we had 11 non-Hispanic white directors and 1 mixed race director. We had 8 male and 4 female directors. The average age of directors was 42. They averaged 11 years in recovery, but interestingly, 1 director was not in recovery. Next slide, please. So like I said, part of this analysis focuses on attitudes toward MOUD. So we had some survey questions on attitudes toward medication. And for the most part, most directors said that it is a good idea for someone to utilize medication like Suboxone or methadone or naltrexone or Vivitrol, or medication for any kind of alcohol or drug problem or emotional problems as well. You can see the large amount of agreement over here on the right. But interestingly, when it came to the question of whether it's a good idea for someone to use opioid medication, substitute opioid medication like Suboxone or methadone, that was the question that directors disagreed with the most. And then when we asked about naltrexone and Vivitrol, there was 100% agreement that it was a good idea for someone to be on that. Next slide, please. So the biggest theme that we saw, or one of the biggest themes here, was this link between channeling lived experience to help address community stigma. So interviewees spoke a lot about recovering out loud to cope with this community stigma by vocalizing their past struggles with addiction and talking about their current situation in recovery. So they're really out in the community sharing their story to humanize addiction recovery. As one director stated, I would love to say we don't face stigma, but of course we do. I think you're always going to face stigma when it comes to addiction. That's why I live my recovery out loud, to show people that we do recover. This may have been where I was, but it's not where I am today. Today, I'm an upstanding member of society. I pay my bills. I'm a valued employee, and I'm on various boards. Next slide, please. And there is also a big theme of directors channeling their lived experience to help out clients or to serve clients through having more empathy for their situation. So lived experience enabled leaders to understand some of the challenges that peers face, including navigating the criminal legal system, for example, overcoming some trust barriers, and just helping them on their early recovery journey, since the directors with lived experience had been there once. Directors with lived experience anticipated common obstacles and offered services to address needs. As one director stated, when I first took over, we didn't have things like socks and underwear on site at all times, but I know, having my lived experience, when you get out of prison, they don't give you socks and underwear. So I use my lived experience to know what you get and what you don't get when you get out of these situations. Next slide, please. And as Rob talked about a little bit, there was this need for directors, or this practice of directors becoming embedded in the community. And they did this through getting out into the community and sharing their lived experience in addiction recovery. Because what we found was that these rural RCCs faced unique challenges in establishing a community presence, and in telling community members that they were there and what their services were all about. They mentioned that in urban areas, they might have more foot traffic, but this isn't necessarily the case in rural areas. So directors were out in the community holding events and making their services known to the community, to humanize recovery, but then also to build relationships with community members through these events. Next slide, please. Yeah, and a lot of these partnerships that were built through directors getting out into the community and telling their story also help them to overcome barriers for their peers. RCC directors use their lived experience to link up with community organizations and social services to really create these comprehensive support networks. And this helped them to come up with some transportation and housing solutions through these support networks and efforts with local agencies and other volunteer organizations. And all throughout, their passion for recovery really drove a lot of these solutions and partnerships. As one director stated, a lot of doors have opened for me because of community members who know me and make introductions, but it's on me to be honest, kind, and transparent about the value of recovery. Vulnerability is key. Next slide, please. But there was some really complex challenges with regard to stigma, and particularly stigma toward MOUD. So RCCs face challenges with internal stigma toward MOUD within the recovery community. Some RCC leaders actually stigmatized this recovery pathway themselves and had negative viewpoints about it. But for the most part, RCC leaders work to create inclusive environments and acknowledge multiple recovery pathways. But a lot of the directors did also acknowledge the stigma within the recovery community towards the recovery pathway of MOUD. One director actually utilized MOUD, and she was hesitant to tell peers and tell community members about her MOUD status because of stigma. This director stated, only a handful of people know because I'm scared of the stigma. Given my position, I worry about the judgment and how it might affect the organization's reputation. I hope one day I can be open about it, but right now I just don't feel safe enough to speak publicly about it. So this really highlights the stigma within the recovery community. Next slide, please. And there was some complex lived experiences with MOUD as well. So there were some directors who had positive personal experiences with MOUD and had MOUD success stories, and this helped them to have more positive viewpoints on MOUD. One director stated, for me, MAT helped me become a functional person. I could go back to school, work, and take care of my kids without cravings. It was a good tool for a long time and worked better than anything else I'd tried. But sort of MOUD misuse, and these really highlighted some of the complexities of this kind of lived experience. As one director stated, my experience with MAT was complex. I used it successfully at times, but there were periods when I misused it, selling doses, running out early, and cycling through addiction behaviors. And in some cases, these negative lived experiences with MOUD led to negative viewpoints towards this recovery pathway. Next slide, please. But there was this really strong theme of education and training helping when it came to MOUD stigma. Staff talked a lot about how training on MOUD reduced stigma and improved their viewpoints on MOUD, and how education that focuses on correcting misconceptions can help kind of correct some of these negative perceptions of this recovery pathway. So as one director stated, before I was doing this job, I used to think, oh, you're just trading one thing for another. But I got more education. I'm a medication-assisted treatment specialist. I went through all the training, and I really think it's a great thing that I wish more people didn't feel ashamed about utilizing. Next slide, please. So there are some important limitations to address here. So we focus just on rural RCCs in one state, the state of Georgia. Our sample size is relatively small for the director interviews with a sample size of 12. We also only looked at rural RCCs, so we don't have an urban control group to compare to. And our survey results on client characteristics were estimates by RCC directors and not actual data collected from clients. Next slide, please. But despite these limitations, we think we have some pretty interesting findings here. So RCCs face significant challenges related to transportation and housing, but when directors were out in the community and becoming embedded in the community and building these collaborative relationships, they were able to help peers overcome some of these challenges. RCCs may fill gaps in the SUD continuum of care in rural areas, including harm reduction services, linkages to treatment, and the expansion of recovery pathways. Most RCC directors did attempt to collaborate with OTPs in the area, but were often unsuccessful. And regarding MOUD, directors generally had positive attitudes toward MOUD and talked a lot about training and education as ways to overcome prior negative attitudes. And RCC leaders channeled their personal experiences in recovery into public advocacy and community engagement. This helped to humanize recovery, reduce stigma, and build community partnerships. But there were some really complex stigma challenges. So stigma from the broader community, and then also stigma within the recovery community toward MOUD and that recovery pathway. And directors address this through a combination of public education, inclusive programming, and intentional efforts to create safe spaces for all recovery pathways. Next slide, please. But we did want to mention some of our challenges in collecting client survey data, which, as Rob mentioned, is still ongoing right now. So initially, we had the survey in Qualtrics, an online survey, and we had directors disseminate the survey to peers and peers could take it on their smartphones or on a computer. But we didn't get much buy-in from that. We got just over 40 survey respondents. So I visited our local RCC, and we found out that a lot of the peers didn't have smartphones. Many were in treatment still, and they weren't necessarily sticking around to take a survey on the computer. So a few months ago, we pivoted to paper surveys and physical gift cards, and have visited a few of these RCCs in person. So our sample size has increased to just over 100. And over the next few months, we're trying to visit a few more and increase that even more. But if anybody has any tips or tricks on how to increase our sample size here, we're all ears, because it's probably been the most challenging part of data collection, but it's been a great experience overall. Next slide, please. So that is all we have, and we appreciate this opportunity and look forward to your comments and questions.
I'm muted. Wonderful. Thank you guys for this presentation. I think we do have a question in the chat as well, and obviously your question in the room about how to do better recruitment of people who are coming to RCCs, the participants, clients, members, whichever vocabulary you want to use. Before we do that, I wanted to turn it over to Alicia to give her thoughts and perspective while people are formulating their questions, and then we'll open up to take on these questions one at a time. Alicia.
I'm Lisa Carpenter. I'm a professor with the Eshelman School of Pharmacy at University of North Carolina at Chapel Hill. And Bettina invited me here because I run a practice-based research network for rural community pharmacies. We have over 150 pharmacies across the Southeast. And so as I was listening to this presentation, I saw a lot of overlap in our rural communities with some of the challenges that you expressed, like challenges with housing and transportation. But in particular, I found this stigma issue around MOUD interesting. We also hear this in rural community pharmacies that, if you have medications for opioid use disorder, you're substituting one addiction for another. So that's something that we also hear. I'm wondering if that, is as pervasive in urban communities, if there's that stigma towards MOUD. I find it interesting the attitudes questions, that there were positive attitudes among directors, but then when you dug into the qualitative data, you seem to uncover some more complexities around that. In the quantitative questions, you could see it a little bit in that folks had more positive attitudes towards Vivitrol, like injectable, versus methadone. And, I'm wondering if it's related to perceptions about risk of diversion, or they just feel like it's safer that way. So really interesting attitudes around that I think also could contribute to some lack of collaboration with the OTPs, like you were saying. So if there's this general perception that some of the RCCs are anti-MOUD, that could make it more challenging to build relationships with OTPs in the area. But those are just some of the observations that popped up when I was listening.
Thank you, Alicia. And for you as well, I believe, like the personal connections. So we heard a lot about the many ways in which RCCs go out to be part of a community, to really make personal connections, to overcome these bridges. And that's something that you saw in your work, or are seeing in your work as well, right?
Yes, the bridging pharmacies, like bridging, we do see that as well. It's important to be integrated into the community. I think that is something that's a little more unique in rural communities, as they're smaller. And so the opportunities to build trusting partnerships, which that also popped into my mind as you're doing this, like it's, how do you build trust in the community? Were a lot of those directors like already from the community, or are they coming from outside? And could that be contributing to some of the challenges in the rural communities? So yeah, definitely an important aspect.
Great point. Great point. All right, I want to bring us back to the question that we had from Sutika. I don't know if you want to post it yourself. The question was for the research team, to what extent are these RCCs doing prevention programming? Is that something that came up in interviews or something you asked about? Did I get that guide, Sutika?
Yeah, thank you, Bettina. Appreciate that. I think he's put a comment in here in the chat, but good to hear it.
Yeah, so they played a vital role in filling the gap for harm reduction, for linkage to treatment, and of course, for the recovery support services. I don't think we heard anything about prevention programming in any of our interviews, and we didn't ask specifically about it. We were hoping that that would sort of organically happen as we had did the interviews with the directors. And Ryan, I don't know if you remember anything related to prevention. I don't think I can think of one thing that they did that would be considered in the prevention space.
No, that didn't come up at all from what I remember. Like you said, mostly just harm reduction, linkages to treatment, and some of the meetings and things that they have there, but not much on prevention programming.
I wonder if you had brought it up, do you think you might have elicited some responses? Just curious if people suppress it, people don't recognize the value of it because it's not something that they're exposed to. I'm just really interested in the correlation. If prevention were to be there, would the stigma come down?
Yeah, I mean, it definitely because of their lived experience, they would be uniquely equipped to go and do school-based prevention, talk to youth, do things like that. And I'm actually I work closely. I'm on the board of this local RCC here, and I'm very familiar with sort of what they do. And we do not do a ton of prevention stuff. So I know that from that unique hat that I wear too. But that doesn't mean that that shouldn't be something that RCCs are also doing.
Thank you.
Sudhika, that's something that we've talked about, like about, the volunteering kinds of work that high school students do. And if you could do volunteer hours in RCCs, if those bridges are ever built. I will say that one RCC we work with, Northern Ohio Recovery Association, they do have a school program. So they do go into schools and have presentations there and do mentoring and so forth. So I think some RCCs do, but I wouldn't be able to put a number on it because honestly, when we did our nationwide survey, we didn't think about that and we really should have. So I'm glad you're raising that question here for us to ponder about. Are there other RCCs in the room who do have prevention programs who want to speak to that? Great question. Great thought. Oh, Benjamin is saying, Benjamin, would you mind speaking more to that point?
No, here in upstate New York in the rural communities, the two RCOCs, well, three that we do have, are all connected to prevention agencies as the parent agency. They're doing child prevention in the schools, anti-bullying, all that type of stuff. And then we do the adult type prevention and harm reduction.
Right.
It's a good collaboration. We go to their events and speak in the high schools and educate parents, things like that. So it's a great working relationship. And we're branching into some youth services here. We're running a youth all recovery meeting in a separate part of our building, and we're going to start doing youth events. So, the new onset age of SUD, I believe, is around 11. So if we're not getting the prevention to end, we're really not making the impact that we're looking for.
I will also say that building connections with schools relies on so much trust, right? And so much mutual understanding of each other. So that the fact that it is happening is remarkable and inspiring. So that is great. Brandon, you pointed out some other prevention efforts. Do you want to speak to that?
Sure, only that recovery support services that are geared more for or towards young people themselves, adolescents and young adults in recovery or what have you. They're much, in my experience, at least locally here in the Boston metro area, they're much more likely to be involved in prevention efforts, connecting with schools, and going in there, for where schools might identify somebody that's at risk of a substance use disorder, other kinds of co-occurring behavioral difficulties. That it seems to be much more common than services, at least here in the Boston metro area, that are geared towards adults.
Right. Great.
Yeah,
I
I
just heard
wonder
someone speak. Go
too.
ahead.
Sorry, I was just gonna say, it would be interesting too to see if that looks different in rural Georgia compared to other areas. This is just kind of based on anecdotes, but it's difficult politically to get into schools and say, I want to talk to high school students about drug use and harm reduction or whatever it might be. So it'd be interesting to see in future research if it looks different in rural areas versus urban areas, just with all the politics involved in that.
Mm-hmm. Mm-hmm.
Just a comment there. In Gainesville, my colleague who's a psychiatrist got a grant from SAMHSA to be able to go spread the education and do all of that. He printed all this up as well as created a website, but the school counselors came back and said they don't have the time to go do that. So it kind of died on the vine, but
Yeah.
it's what it is.
Yeah. That's challenging.
Yeah. A couple more comments here from Kai and Bo too.
I can speak to Stansel's question. We did have a question where we asked the directors about accommodations for disabilities, and nearly all of them talked about being handicapped accessible, but that was pretty much the extent of it. So that was definitely an area where RCCs can do more to accommodate for a wide range of disabilities.
Perfect. Thanks for tackling that question right here. And I see also that Kai has some perspective from Vermont, if you want to share.
Yes, hi. I'm a person in long-term recovery, and I volunteer with one of our local recovery centers. And we have here in Vermont, we have prevention-oriented coalitions, and they're funded with the part of CADCA, which is Community Anti-Drug Coalitions of America. And it's many of you may have heard of this, and they're a national organization. And they solely work in prevention in the schools and with the coaches, the student coaches and all. And we in the recovery group have partnered together with the prevention group, because prevention is also part of, staying in recovery. So it's really, I think it's a beautiful combination. So thank you.
Yeah, thank you.
The comment from Ben just jogged my memory. There was one RCO was located in our RCC. Georgia refers to their RCCs as RCOs, an RCO network. There was one in South Georgia they had a grant to be in the schools, and they did something very similar to what Ben talked about in his comment, where they would work with a peer was specially trained to work with identified at-risk students. So there was that is one example.
That's awesome. That's very inspiring. And then Bo also reminded us that there's collegiate recovery programs that have, of course, access to a different student base. Bo, do you want to speak to that? And do you happen to know if there are collegiate programs in Georgia?
Yeah, well, my information is a little bit old, but University of Georgia had a program a few years ago. Kennesaw State is one of the biggest recovery college-based programs in the country, and so in terms of prevention work, a lot depends upon who is running the different collegiate recovery community. Sometimes these people are very comfortable in the prevention space. And sometimes they are people who don't come from that background and themselves. They have a lot of recovery lived experience, and then what I've seen sometimes is them getting into the college community and given presentations to reduce stigma and share recovery messaging in the college community. Whereas some, I think, go into the broader community, but I see more and more work in the college community itself. I think that's trying to make sure that the administration is aware of what they're doing and increasing the visibility of their group to justify them being there and trying to have an impact on the overall drinking culture at schools.
Mhm. That
I'll
makes sense.
have to throw in a plug for our collegiate recovery program that we have here at Georgia Southern University. It's called the Center for Addiction Recovery. And I was actually a student at it from 2016 to 2018. Now both Ryan and I sort of help support it and help run it. We used to be, and it's a long story, but we used to have lots of students, 30 to 40. Now we have about 8 to 10 that are actively engaged. But when I was a student, we regularly went into the wellness classes on campus that all the students had to take, and we would give our people that were part of the collegiate recovery program would give their stories, and it was usually very impactful from my experience doing it as well as the experience of my colleagues doing it, and so that's actually something that we hope to get back to doing as we build up our student base.
Amazing. Now, are they aware of RCCs in the area, or are they separate and not interacting? The collegiate program that you
We
have
have a very strong relationship with our local RCC. We actually are having the director come in and do a peer support group for one of our seminars in a couple of weeks. So we work pretty closely with our local RCC.
Awesome. Awesome. I also want to circle back before we add time about the question about how to recruit RCC participants into studies. Anybody have any thoughts, suggestions, ideas, questions about it? So the challenge really was that you did have RCC directors and you did have RCC staff who told their peers about the survey, but then even though there was access to computers at the RCCs and people were physically in the building being told about it, very, very few participants took you up on the offer of taking the survey. Did anybody report back about what the barriers were about they was it not enough money? Was it the survey was too long? Like, did anybody tell you barriers back, or was just a general blanket silence?
Yeah, we didn't get too much feedback on it. I mean, when I visited the local RCC, I realized that not many of the peers have smartphones, so it was difficult for them to take the survey. I also do think the survey was a little too long. I think that administering some of the paper surveys and realizing how long it took, we didn't get specific feedback on that, but I think that Rob and I would probably both agree at this point that that was also kind of a barrier. Yeah, and then I think it probably differs across RCCs, but the one that I visited, the peers weren't really hanging out for too long. They would come for the meetings and then leave most times. So they weren't going to stick around for another 30 minutes to take the survey on a computer. Yeah, so those were some of the barriers specifically that we saw.
Yeah. And it was so that you said they're just kind of coming in and leaving. They just didn't have the time to, or less interest. Like they were busy going from one job to the next, or picking up kids, or was it just like, research? I don't really need to do another questionnaire at this time.
Well, many were in treatment, so they would come for the meetings and then go back to the treatment center. I know that the RCC Rob visited, he had a different experience. If you want to talk about that a little bit, Rob.
Yeah, and just to elaborate a little bit more on the challenges. So again, them coming in for the recovery meetings and then quickly leaving. Be a lot of them being in treatment. The e-gift card was a barrier too.
Yeah.
I could even hardly figure out how to use the e-gift card.
Oh, so like it wasn't like an easy link. You had to jump through hoops to get it?
Yeah, we use the Tango platform and they send it to you via email, but they're a bit restrictive in the way that you can use it. It's sort of it's not like a physical gift card. And
Oh.
yeah, so that those are the main reasons. And then the other thing was we were relying on the RCC director and staff to put up our flyer and to talk about the study and to promote it. And that was sort of what we needed to be doing. And so we came together as the research team. We pivoted to the paper survey. the physical gift card, and actually visiting the RCCs ourselves. And some of the RCCs are very close to recovery housing in the area, and so there was actually one that was fairly close by, about an hour and a half away, and we were able to get when the recovery house came to the RCC to get services, we were able to work with the recovery house director, who also worked at the local RCC, to get those surveys done. So we sort of had to plan a time for them to be able to actually take the 30-minute survey, because I mean, technically they were in treatment, they have a very structured day, and so it's just very difficult to sort of organically promote this survey and them sit down and take it.
That makes a lot of sense. And I think that what you mentioned about pivoting to paper seems to be in line, Benjamin, about what you were saying. Just you were thinking about the extra step of making part of a one-on-one with a recovery coach.
Yeah, we've had other studies that, social determinants of care, other things that I've filled out with, we have 12 peer professionals in varied settings at this RCOC, and they all have scheduled one-on-one, so that could be worked into one of those sessions to have that survey filled out.
Interesting. That sounds great. If there's availability to do that and staff buy-in to do it. That's awesome. We are at the hour, so we are sticking around for the next half an hour for the recording that's going to go online afterwards. We will cut it here. We'll keep recording running, but it'll only go up to this point, and everything else we will take note on. So for most of you who still have time to ask further questions or dive deeper into itty-gritty pieces, please stick around. And for everybody else, I really appreciate seeing you today. It's good to be part of this community, and I hope you have a wonderful weekend. Whatever questions